Hi, and welcome everyone to our first Wisconsin Knowledge Boost session. My name is Jonathan Ferguson. I'm a financial capability specialist at UW Madison's Division of Extension, and I'm glad to be with you here today. As you know, over the last year, there have been many changes to important public programs. Those changes have been challenging to navigate for Wisconsin residents and the professionals who support them. To help do what we can to minimize this challenge, UW Madison's Institute for Research on Poverty and the Division of Extension have partnered to offer this virtual learning series. Sessions in this series will be offered quarterly, and certainly until it becomes clear that navigating new changes in public policy is no longer an issue. Over the coming year, you can expect more sessions on topics of importance to Wisconsinites. Also, I should mention it's important to note that views expressed by our speakers don't necessarily represent the opinions or policies of the Institute for Research on Poverty, UW Madison's Division of Extension, or any of our other sponsors, including the University of Wisconsin-Madison. We're starting our series with a focus on Medicaid. One of the reasons we chose to discuss Medicaid policy first is due to the scale and scope of impact that policy changes could have for Wisconsin and the nation. The federal budget reconciliation bill passed in July includes changes to Medicaid policy and other human service programs like SNAP. 1 in 5 Wisconsinites uses Medicaid for their health insurance. So any policy changes that have the potential for statewide impact on individuals' eligibility and coverage, but also on our health care provider agencies, it's very notable. We will begin today's session by hearing from our featured speaker, Bill Hanna, the Wisconsin State Medicaid Administrator at the State Department of Health Services. He'll describe the nature of the Medicaid and SNAP policy changes, and we'll explore what the estimated impact on the state's Medicaid population might be given currently available data. We'll then turn to our panel for commentary on the policy changes. Our panel includes Brandon Verwink, who is Wood County Human Services Director, Bob Rarrett, who serves as St. Croix County Health and Human Services Director, as well as Adam Van Spankeren, who serves as Navigator Program Manager for Covering Wisconsin. As County Health and Human Service Directors, Brandon and Bob will share their perspectives on the possible impact of the policy changes on their service populations and their regional healthcare providers. From Covering Wisconsin, Adam will add his perspective on possible impacts to the Medicaid eligibility and enrollment process. From there, we'll move into an open Q&A. So throughout this session, please feel free to drop questions in the Q&A box as our team will collect unanswered questions and include them during this open session towards the end of our time together. Also note that this session is being recorded and the recording will be added to UW Extension's YouTube channel in the coming days and will also be made available to you by email. With that, we'll start with Medicaid Administrator Bill Hanna, who will provide a brief overview of the Wisconsin Medicaid program. After Bill's overview, he and I will continue this important discussion. Turn it over to you, Bill.
All right, good afternoon first. Thanks to the Institute for hosting this important conversation. We're going to start with just a brief overview of what is Medicaid in Wisconsin. Forward here. So to give you the breadth and scope of what Medicaid is in Wisconsin, Medicaid in Wisconsin covers 1 in 5 Wisconsinites. That's well over 1.2 million adults and children in Wisconsin. What Medicaid covers is very similar and often above and beyond what your commercial health insurance covers. So it covers doctor's visits, prescriptions, vaccine coverage, urgent care, emergency care, It also covers long-term care, which is pretty unique to Medicaid. So it'll cover long-term nursing home stays. It also covers many individuals with disabilities to allow them to live in their home or in the community rather than in an institution. And Medicaid is a primary funder, one of the biggest funders nationally of mental health services. To give you a breakdown of the individuals in our Medicaid program, you can see that just under half are children under the age of 18. The next largest category are adults over 65 or individuals with disabilities, primarily served in our programs to allow them to live in their home or in excuse me, to live in their home or in the community. Next are adults 19 to 64. And I'd ask you to just keep note of that population as when we move to the next part of the conversation, that is really the population most impacted by the changes in the federal bill. And then the smallest group are adults that are parents or caretakers of children. And then 1% are pregnant individuals. Of course, that is regularly changing. Another important aspect about Medicaid is that you can see it's well utilized across our state. Sometimes there are misconceptions that Medicaid is primarily an urban service, and the map shows that that's just not true when we look at percent of population on Medicaid within a given county. Of course, you can see there's a darker greenish color in Milwaukee and Menominee County, but you can also see parts of northern Wisconsin have a high percentage of their county's population enrolled in some version of our Medicaid programs. To emphasize that even more, we did some analysis to break down counties into rural counties, sort of our mid-sized counties that we have in Wisconsin, and our real urban counties in Wisconsin. And you see in the urban areas and sort of our suburban counties, it's about 25% of the population on average in those counties that are enrolled in Medicaid. And when you look at only our rural counties, it's about 25% of the population in rural counties are enrolled in one of our Medicaid programs. Similarly, there's some misconceptions about the racial breakdown of the population within Medicaid. You can see that, again, just under half of our population is white. You can also see we have a large segment that is not provided, is not required to be provided. Race and ethnicity are not part of the eligibility practice, and therefore it's not a required field. But just to dispel some of the myths that it is, again, primarily an urban or Milwaukee or a Black or Latino program, you can see that it serves all Wisconsinites across the state. Again, dispelling some of those myths. So often folks think once you become 65, right, you're on Medicare, and Medicare pays for all services for older adults. Medicare pays for hospital services. Medicare does not pay for long-term care services. Medicare pays for limited stays in nursing homes, and Medicare pays for limited support to keep people in their home or in the community. The primary funder, like I said earlier, of long-term care in nursing homes and to keep people in their homes is Medicaid. And Medicaid pays for 3 in 5 Wisconsinites that are living in a nursing home. Medicaid is also a big funder of births. 40% or 2 out of every 5 births in Wisconsin are funded via the Medicaid program. And includes coverage not only for the birth, but leading up to the birth in our prenatal care and, of course, postnatal care. Unfortunately, in Wisconsin, we only cover individuals after they've given birth for 60 days. We are one of 2 states that does not offer 12 months of postpartum Medicaid eligibility. It is Wisconsin and Arkansas. This was a federal law change several years ago. and we have not been able to work with the legislature to get 12 months of coverage postpartum after giving birth. Like we showed before, but sort of another way to show it, about 40% or 2 in 5 of all Wisconsin kids are covered under a Medicaid program. We have higher eligibility thresholds for individuals who are pregnant and for children, and therefore Medicaid is a big funder of children's health care in Wisconsin. It's also a big part of the healthcare economy. You can see there are over 170 hospitals in Wisconsin that accept Medicaid as payment, 324 nursing homes, long-term care facilities in Wisconsin, and over 30,000 providers of all sorts, physicians, therapists, mental health providers that receive and accept and care for the many individuals enrolled in our Medicaid programs. Again, how much does Medicaid contribute to our healthcare economy? It's about $15 billion in a year. Here's a breakdown of roughly some rough numbers of where that funding goes, including $2 billion in prescription coverage, $1.2 billion for nursing homes, over $600 million in behavioral health care, and considerably more to our hospitals. A quick background understanding of how Medicaid is funded. We could spend probably 3 hours just talking about Medicaid funding, but in general, Medicaid is a partnership between the federal government and the state. And in Wisconsin, the federal government pays about 61 cents of every dollar that we spend. That is different from state to state based on a number of factors, primarily related to the poverty level of the state. Ranging from a 50-50 match all the way up to a 75% match. Wisconsin has pretty consistently been around the 60% mark in terms of the federal share of our Medicaid program. So I also want to, there's a lot of different flavors of Medicaid, and you may have heard it be called many different things, and that is part of the confusion when we start to talk about Medicaid. Sometimes it's called Forward Health, and everybody in Wisconsin that's enrolled in Medicaid has a Forward Health card, but then they're often also enrolled in one of our programs. Badger Care Plus primarily covers children and adults, healthy children and adults. We have the Children's Long-Term Support Program, CLTS, covers children with disabilities. We have Family Care Partnership, IRIS, and PACE, which are various versions of our long-term care programs for adults, again, keeping individuals in their home and in the community and out of institutions. If you hear any of these programs, they are all Medicaid programs. They are all Medicaid-funded programs. It just goes by many names. And lastly, I just want to also highlight, not only am I the administrator for Medicaid in Wisconsin, but also Food Share in Wisconsin, known as SNAP nationally. About 67% of the Food Share members are also enrolled in Medicaid, and we have about 685,000 families receiving SNAP benefits, which also is a big contributor to the Wisconsin economy and was greatly impacted by changes in the federal reconciliation bill. So I'll stop sharing there. That was a real fast overview of the breadth and scope of the Medicaid program in Wisconsin.
Thanks, Bill. That was a great overview to really lay the foundation for what we're talking about today. So now let's move into discussing what is known about the budget and policy changes affecting the Medicaid program and SNAP as well, insofar as you want to include that. So what are the policy changes? How might they affect eligibility and enrollment coverage and financing of these programs?
Yeah, so there's 3 or 4 big categories of changes that I'll talk through. The first, and probably the one that's getting the most coverage, are changes to work requirements for both SNAP recipients and for Medicaid recipients. The second is some other eligibility changes, and we'll talk about the difference between Wisconsin and many other states. The third is lots of changes to how both SNAP and Medicaid are financed. And the last is the rural health transformation funding. So 4 big buckets in the bill. First, I want to clarify, Wisconsin is unique. There is no state like Wisconsin. We are not an expansion state, although many of you are familiar, we've sort of done our own quasi-expansion through a waiver called Badger Care. For most of the bill, the federal bill differentiates between expansion states and non-expansion states. If you're an expansion state, you have to follow certain rules. If you're a non-expansion state, there's a different set of rules you have to follow. In most cases, when you read that bill, Wisconsin is treated as a non-expansion state, except for work requirements, because the bill specifically calls out expansion states or states that have covered a similar population via a waiver. And that's exactly what Wisconsin has done. We cover adults up to 100% of the federal poverty level via a waiver. And so if you remember back in my slide, I was talking about those 19 to 64-year-old population that do not have children at home. That population will need to meet work requirements beginning January 1st of 2027. The federal bill did give the HHS secretary the ability to grant extensions for those. CMS has already come out, the federal agency that oversees us has already come out and said they are not likely to grant extensions. So we are working towards a January 1st, 2027 implementation date of work requirements, which means that population of adults between 19 and 64 will either need to prove that they are meeting work requirements, which means they are working at least 80 hours a month, volunteering 80 hours a month, participating in some sort of job readiness program, or enrolled half-time in school in order to meet the requirements, or qualify for a whole list of exemptions that were spelled out in the bill. The team is working hard right now because the bill sets out the big framework, but doesn't give enough detail. And we are talking to CMS regularly to start putting together those details so that we can communicate to individuals about what they would need to do to meet those work requirements. The best thing that individuals can do today to be ready for that is to make sure that their contact information is updated with their county or with the state, so that when we have information, we can text them or email them, send them mail, send them the letters on what they will need to do come 2027. We estimate that this will impact about 63,000 individuals in our program today that we can see are not meeting the work requirements. And so we'll be working over the next year and a half to either get them ready or see if they qualify for one of those exemptions. The second change is, and this is a clarification, so most states that are an expansion state, that same population will have to do their Medicaid renewals every 6 months. That does not apply to Wisconsin. Again, we are a non-expansion state, so we will continue to operate on an annual renewal process. Now, individuals are always required to report changes to their county or to the state, but their sort of annual recertification will continue rather than a 6-month recertification that most other states are working towards. The other eligibility change is that under previous law, when somebody applies for Medicaid, we can actually look back 2 months prior and backdate their eligibility. So if they had a hospital expense and they were uninsured, but they would have been eligible for Medicaid last month or the month prior, we can backdate that and Medicaid can cover those costs. Today, we can look back 3 months. Beginning January of 2027, that look back period for all populations will be only 2 months. And so it'd be really important that individuals make sure that they timely complete their Medicaid eligibility. The third big bucket was really changing how Medicaid is financed. Fortunately, through the leadership of Governor Evers and in partnership with the legislature, we were able to get the state budget signed on July 3rd, really just hours before the federal bill came into law, which means we were able to draw down nearly $1 billion more in federal funding for our state Medicaid program and for our hospitals. Had we not been able to do that, because the new bill sets in grandfathering clauses, had we not been able to do that, we would have been locked out of that Medicaid funding. I want to talk a little bit to the SNAP financing changes because that has immediate impacts today, this year, and in this biennial budget, right, that ends in about a year and a half. So a couple changes to SNAP. Today, SNAP administration, the cost to run the program is split 50-50 between the federal government and the state. Beginning next October, that changes, that's October of 26, that changes to where the federal government is only going to provide 25% of the cost to run our program. We did not get any new tools. We did not get any new waivers. We did not get any new efficiencies. We did not get any reduction in the amount of work we have to do to sort of make up that loss of federal funding, which means we need $43 million to finish this biennial budget to just maintain our SNAP program, our food share program as is. That's to support both state work and work that our county agencies do to certify everybody when they do their SNAP applications and renewals. The second piece is it greatly expanded. There are work requirements today for individuals on SNAP. It's people without children between 18 and 54. The federal bill expanded that up to age 64. And for the first time includes individuals who have children, so long as their children are 14 years or older. So we've significantly expanded the pool of individuals that have to meet work requirements. We have a program in Wisconsin called FSET, Food Share Employment and Training. That is one of those job readiness programs. We anticipate, because we're expanding the pool of people that need to meet the requirements, that our enrollment in that program will go up. That's about another $14 million to finish this biennium. Wisconsin has been very fortunate in that we have always fully funded our employment and training program because we think it's important both that people have access to food and have the tools or the ability to roll in a program to meet the job readiness program and ultimately move on to employment. And then the last piece, historically, the benefits that go to each individual that show up on their Quest card or their EBT card has always been 100% federally funded. The bill now makes states pay a portion of that cost if their error rate, that is how accurately we calculate an individual's benefits, exceeds a certain threshold. If Wisconsin's error rate goes above 6%, Wisconsin will have to pay $69 million a year to maintain the SNAP benefits, all the way up to $202 million a year, depending on that error rate. Now, Wisconsin historically has had a pretty low error rate. However, federal changes create more risk. And in order to guarantee that we keep that error rate low, we need more resources, both at the state and at our county partners, to do an additional check, right, to make sure that our errors stay under that, and that's an additional $11 million. So we're all told, and the governor has asked the legislature for $69 million to maintain our food share program through the rest of this biennial budget. Lastly, the last big item that was in the federal bill is the Rural Health Transformation Funding, and the application for that just went out earlier this month. It is $50 billion nationally over 5 years. Half of that will be distributed evenly among every state that submits an application. And I think everybody expects that all 50 states will submit an application. So at a minimum, we would expect about $500 million over 5 years focused on rural health transformation. The other 25 billion is distributed based on a number of factors, including sort of a ruralness factor. We anticipate states like Alaska, right? They pretty rural, big state. So that's a big factor. Wisconsin again ends up in the middle, right? We're not as rural as some of the western states, and we're not as urban as New Jersey or some of the New England states. There are also policy factors and other data metrics that go into that. It's unclear at this point how much of the other 25 billion and how that will be allocated until every state submits their application. We did just complete a request for information and got lots of feedback from partners all over the state and nationally on how Wisconsin should invest that funding. And the department is working hard to prepare for our submission, which is due at the beginning of November, and expect to hear awards at the end of the calendar year.
Wow, thanks so much for all those details, Bill. I think it's a good thing that this is being recorded because if I were in the audience, I would definitely go back and re-listen to some of it because there's just so much to keep in mind. As we look ahead, I'm wondering if there are other economic, political, or healthcare system changes expected to occur in the next couple of years that could increase or decrease the impact of Medicaid policy changes. You've talked about the recent budget that was passed, but looking ahead, are there other things that our audience should be aware of that could impact everything that you've mentioned or any of the things that you've mentioned thus far?
Yeah, I think it's always important to remember that healthcare is a healthcare ecosystem, right? And impacting one part of the payer mix or the ecosystem impacts all of us. So I focused on Medicaid, right? So we have about 63,000 individuals. We know not all of them will meet the work requirements or an exemption. So we do expect that that does increase the uninsured rate in Wisconsin. There's also a provision in the bill that if somebody doesn't meet the work requirements, they are not eligible to buy insurance on the marketplace with a subsidy, right? So then they're sort of stuck in this gap. We also know that marketplace subsidies are ending, which will also make health insurance unaffordable on the marketplace for many individuals, especially in Wisconsin, where we don't cover up to 138% of the federal poverty level. In Medicaid, we only go to 100. And the marketplace was really designed. So if you're in that 100 to 138, it really becomes you get priced out. And the total estimate between the marketplace and Medicaid is about 270,000 Wisconsinites. So we anticipate that that will have an impact on the uninsured rate. When the uninsured rate goes up, that creates uncompensated care for all types of providers, right? Individuals still need to get healthcare services. They now just don't have a way to pay for it, which means hospitals, physicians, and other services just have to eat it, or that's what's called uncompensated care. And in order to make up that lost revenue, right, it gets passed on to all the other payers. So while you may not be directly impacted by this, it will have ripple effects across our healthcare ecosystem because it's all connected, right? And it's all one big system.
Yeah, that's food for thought. Lots of things to think about, and I imagine that a lot of folks on the call now are wondering if there are things that you might suggest that they do in their roles as either practitioners who help residents or folks who work in health and human services throughout the state. Are there any specific actions you might recommend that they take? And that'll be my last question for you before we move to our panel.
Yeah, I think the key focus sort of going is to not take our eye off the ball over the next year as we gear up to try to keep as many people enrolled as possible. And I think some of our next guests can talk specifically about that. But to the audience, I think stay connected as we roll out this information, make sure Medicaid recipients are aware of these changes and how it will impact them. The department is working on communication tools and data sharing tools with healthcare providers and healthcare payers so that we can keep as many people covered as possible. And again, we're going to try to minimize the burden as much as possible on the individual having to prove that they are still eligible.
All right, thanks, Bill. I'm sure we'll have more questions for you during our Q&A, but for now, we'll turn to our panel. So I'll welcome those folks on. So I'd like to get started by giving each of you a minute to introduce yourself and summarize your agency's role related to the state Medicaid program. So for Brandon and Bob, could you briefly describe your county area's population and healthcare provider system as they are relevant to Medicaid? And for Adam, I'm just hoping you'll share a little bit about covering Wisconsin's role. So maybe we could start with Brandon and then move to Bob and then to Adam.
Thank you. In Wood County, we are one of those counties that when we look at Bill's PowerPoint, we were a little bit darker. So we're a rural mixed county where we have two smaller cities on each end of the county. And the county services really provide a lot of mental health services within Wood County. We also have a number of other smaller providers and two larger health systems. We have Marshall Clinic Health System along with Aspirus Health System as well. So it's a pretty diverse health system for a county our size. So we do have provider options. However, when you look at the population of our county being 75,000, our Medicaid population is just over 19,000. So we fall in that about 1 in 4 of our residents are Medicaid recipients. So they're accessing medical care through the Medicaid program. So we do have a strong reliance on good Medicaid coverage for our residents. So if we see that population fall a bit or fall off Medicaid rather, certainly it's going to be a significant impact that will cascade to our providers and our county agencies as well, as we see more of a need at the county level that we certainly will try and fill that gap in. But there certainly is a cost to taxpayers as well as that role is filled by the county.
Thanks, Brandon. Time for you, Bob.
All right. Thank you very much for having me today. I'm coming to you live from the WCA conference, so I hope I don't get any noise interference here. Just quickly, St. Croix County is a county of just over 100,000 people. We're one of the fastest growing counties in Wisconsin. Our Medicaid population in terms of who our Health and Human Services Department serves is makes up approximately 66% of our revenues outside of tax levy. So we have a strong reliance on Medicaid to keep the lights on at our Human Services Office. We have a mix too of hospital systems and nonprofits, and of course all of our human service and public health programs that we interface with that, again, to use Bill's words, with that ecosystem of healthcare, recognizing that our populations or those that we serve also interact with these other health systems. So we have formed a system of care by which we work very closely with our partners who are also reliant on Medicaid. We're a mix, the last thing I'll say is we're a mix of urban and rural. We have a couple of Hudson, and then we have a couple of other relatively large population centers in relation to Wisconsin terms anyway, and then a broad rural population that we serve. So there's a lot of geographical distance for people to navigate when they're trying to get health care to begin with, and those work requirements will play a role in whether or not they can meet them.
Thanks, Bob. Appreciate it, especially given what you have going on right now, making time for us. That's great. Adam.
Right, thank you. Yeah, Covering Wisconsin, people don't know, is a program of the UW-Madison Division of Extension. So we are a part of the Health and Wellbeing Institute, and we are the state's only navigator organization. Now, if you don't know that term, it's really important for people. We talked a lot about people in Wisconsin who are interfacing with this ecosystem, trying to figure out where they fit in to get care and coverage. Navigators, I have the privilege of leading this incredible team of dedicated, knowledgeable health insurance experts, which is what navigators are. And they're going to help just anybody who really needs help applying or understanding these programs. Whether you talk about Medicaid, you saw Bill go through that list of Medicaid programs. I mean, any point in there is potentially a point of confusion, and anyone can get stuck in that process. Same thing with the ACA and the marketplace. So we are on the front lines helping people connect to those programs so they can actually go and get care and use that care. So we're focused on applying, educating, and just making sure people don't get stuck in the process.
Thanks, Adam. Covering Wisconsin is clearly a key piece of being able to support the Wisconsin residents with healthcare. So it's great to have you here today to learn more about the office and what you all do. Our next question is going to be specifically for Brandon and Bob. And Brandon, we can start with you on this one to hear your reactions to the policy changes Bill described, and more specifically, how might those policy changes impact your healthcare provider system and workforce in your area?
Yeah, I suspect there's going to be a pretty significant impact as we look at a number of folks not meeting work requirements or not able to meet the work requirements. It's going to pose a significant challenge. Currently we still have folks that we serve at the county level that are uninsured or underinsured, and we do our best to serve them from a sliding fee scale, and sometimes they're not able to make payment, but we always want to try and serve them. As we look at that population of uninsured continue to grow because of the loss of benefits, that certainly, as Bob talked about, is going to have a cascading effect on the revenues coming into our department. And when you look at a loss of revenue into our department, you're going to see not just an impact on folks that are receiving behavioral health services or other Medicaid-related services. You're also going to see a crunch countywide for other services. So I think that gets lost in the conversation. Counties under tight budget constraints, and they fund a multitude of different services that people come to expect, from snow plowing to law enforcement. And if there's a crunch at the county level because the Human Service Department no longer has revenues that they had in the past, you're going to see a loss in services countywide, not just directly affecting Medicaid recipients. But we're also going to see a long-term impact. So it's going to, in my opinion, be kind of a slow burn. You're going to slowly see people losing benefits and access to health care. And maybe the impacts won't be immediate for some, but as you look down the road and people not having access to behavioral health services or mental health services, you're going to see a significant impact long-term on outcomes. And I think that's something that's going to be incredibly difficult. It's hard to measure, certainly right off the bat, but we are going to see some upticks as people no longer have access to that care. One other thing that Bill talked about that I think also is going to be a significant impact is the reduction in funding for SNAP. I know it's conversations about Medicaid, but since Bill brought that up, with counties having to now cover counties or the state covering 75% of the administrative burden for eligibility, you're going to be looking at a significant reduction in revenue to the state, or as the bill spelled out, counties. So if the state can't pick up that share, the counties will have to pick it up. And just to give you a little snapshot, that cost to Wood County alone, in my estimation, is about $180,000 a year. So $180,000 a year, you're looking at a couple of therapists within our building that it funds. So we're talking about some big impacts that food share and SNAP eligibility is going to have on counties as a whole, and that's incredibly concerning.
All right, Bob, your thoughts?
Yeah, and to add to what Brandon said, I think what we're seeing is, after decades of progress trying to move upstream of high-cost care through early intervention and prevention work, what we're seeing, or will see with these changes to Medicaid, is a swing back to deep-end service costs. We're going to see a lot of uncompensated care at hospitals, as Bill pointed out, emergency departments, and we're also going to see those an increase in events in our crisis department, where people are going to require hospitalization or some high-cost service as a result of a crisis call. The other point I wanted to make, I think, was the public's health and the public safety are not mutually exclusive. So when you have more people, as I think Brandon pointed out, as you have more people in the community with untreated symptoms for behavioral health, they're going to encounter law enforcement more frequently, and they're going to end up in jail oftentimes for those encounters. So you have the situation where public safety will end up responding to more calls related to behavioral health crisis. Jails will start to fill up with people who have behavioral health concerns, and counties will be in a position where their funding is decreased because they're not bringing in the revenue that they once did for Medicaid, and because they won't have the personnel to respond to the increasing presence of people in the criminal justice system. So you have this sort of perfect storm of moving the costs upstream or downstream where they cost more, and having an increase in that population, while at the same time reducing the revenue to the people who can actually respond to those kinds of crises. So I think public safety and public health will see a joint impact, and it goes more broadly to the whole safety net system. But you will see this broader impact to public safety that I'm not sure people are probably starting to grasp what that might mean, at least in our local law enforcement agencies and our sheriff's department. But I think it's something maybe to point out going forward, that these costs are shared amongst not just people who have to pay higher premiums, but for our public safety, who is also, at least our sheriff's office, is funded through tax levy. Tax increases, higher premiums, and an increased population of people that are untreated.
While both of your answers had a lot of rich information, but I'd say a primary takeaway for me was just the domino effect that's known and maybe unknown that could stem from this. Moving ahead to our next question. DHS estimates the new policies may lead to significant Medicaid coverage losses, which Bill talked about. If so, Wisconsin will inevitably experience shifts to other forms of coverage or increases in the uninsured population. What types of coverage shifts might be expected in your county population or statewide Medicaid enrollment declines? If the uninsured population increases, can you describe the impact your community and healthcare system might expect? So for this one, Adam, we'll have you answer this from your perspective at covering Wisconsin, and then maybe we'll have Bob respond, and then to Brandon.
Sure, thank you. Bill did a really nice job outlining what these changes will mean and about how many people we estimate right now will be affected. And I think that, with our experience of covering Wisconsin, we see kind of people trying to access, the healthcare system from all different angles. And right away, Bill did a nice job carving out the kind of 60,000 plus people who aren't currently meeting work requirements. And it's important to know, and Bill did say this, that they're not going to necessarily then be able to go to the marketplace and get tax credits, right? And not be able to get those subsidies. Which means that there's going to be people, navigators like my organization, or people at the county level, or nurses, and basically anyone that a consumer is going to interact with throughout their kind of healthcare journey is going to be helping them with kind of paperwork, trying to figure out if they get an exemption, trying to figure out, how they can meet those work requirements. And it's just really important to know that those barriers exist. Now, there will be a lot of people who will, I think a lot of people who, what we see as navigators in our experience, if they can work, they are working, right? Like if there are jobs out there, they're already working. So we might see people trying to pick up additional hours, additional jobs, meeting those work requirements, and they could get priced out of Medicaid, which then they can go to the marketplace and get financial assistance, get those subsidies to pick a marketplace plan. It might be the result of working 2-3 different jobs. So we'll see, how we can, as navigators and then anyone else in the system, help those people then get to the marketplace. Now, I think it's important to know that our state's Medicaid system, the history of it, it does work a lot like private insurance. And people, you pay a copay. It might be a very nominal copay or zero even, but getting used to private insurance that you might get to the marketplace is something that's pretty easy to do. But what people need to do is learn terms, like deductible, out-of-pocket maximum, co-insurance, those things that a lot of people who've been on the Medicaid program, maybe for their whole lives, their whole adult lives, don't yet know. And that's where our organization, Covering Wisconsin, is poised to educate. But it's not just us. It's anybody who is a trusted member of the community that folks are interacting with is going to be in a position to help them understand the transition to their other insurance coverage and how to use it and how to access healthcare.
Thanks for centering that and that very practical thoughts. The practitioner side of me really tuned into a lot of things that you mentioned there. So yeah, Bob, your thoughts.
Could I ask, Jonathan, could I ask that Brandon go next because there's an especially noisy event?
Oh yeah, absolutely. Absolutely. And Brandon's okay with it. That is.
Always happy to help. So, yeah, certainly I think the strain on our system is going to change. As county human service departments, our goal is always to try and connect folks with services. That's meets our mission, and it will cause a bit more stress on our staff because they'll get stressed because not that helping someone is stressful, but it's stressful when someone needs care and they can't afford to access it. So we'll be connecting certainly with Adam's group and other folks within our community that can also help assist folks in finding insurance. But that's going to be a little bit of a different ballgame for us. We're not accustomed to doing that as much. Over the last several years with the Affordable Care Act and the subsidies and with our Badger Care program, we've had good coverage in the state of Wisconsin. So it's going to be a relative change for us. We will adapt to it and do our best to make sure that people find coverage. But when people don't have coverage, certainly the economics are going to play a factor on our systems as well, just because we are certainly charged to serve individuals that need that care, but we're not going to see the revenue on the backside for providing that care. So certainly a large challenge for us moving into the future.
Thanks, Brandon. Bob, how are things going?
Well, it's as good as it'll get. So
okay.
I don't have too much to add to what Brandon said. I think I am a little bit concerned about the possibility that many of our benefit specialists could see a very angry public as a result of these changes and the kinds of with the tension in the country right now and the political tension around some of these changes. I think there is some concern that we will become, that is, local government will become the focal point for the public's frustration and anger around these changes. And it's a consideration. I don't want to solve a problem that hasn't happened yet, but it's just an anticipated sort of wrinkle that maybe I hadn't thought of initially when we looked at all the other complications with this. Other than that, I don't have too much to add to what Brandon said.
Okay. Well, thanks for your addition. It highlights an important point. So the last question we have before we move into the open Q&A, and so Bob, because you seem to be able to navigate the noise challenges, we'll start with you. So are there other economic, political, or healthcare system changes expected to occur in the next few years that you think could increase or decrease the impact of Medicaid policy changes in your specific area? So this is the same question I asked Bill, thinking from a statewide level. Were there anything specific in your area that you can think of, considering you all have mentioned how much the interconnectedness of all of this is really key? So any thoughts there?
Well, if you can call it good news, the good news is we know it's coming, right? So there's a storm coming, but we have a little time to prepare, at least to mitigate some of the damage from it. I think that's our plan going forward, is to do some of the things that were already mentioned around ensuring that people who already have Medicaid can retain it by including in their care plans, their treatment plans, or whatever it is we have with them, whatever agreements we have with them, that Medicaid coverage is a part of that, and ensuring that we try and help them as best we can to retain their Medicaid or attain it if they don't have it already. So really a focus on helping people navigate these new barriers that will be in place if they aren't already. I think the concerns far outweigh any of the possible good news I could offer. And I don't know that we should even try to downplay the impact that this will have on our public, because I think it's important people know that these changes will have dramatic effect on the healthcare system and on the safety net, which is quite frankly strained already. The shift in all of these things that we've talked about will again drive up costs in our area because of the expense related to people that require hospitalization. And those expenses are already climbing above what we budgeted for last year and will continue to go up, primarily around placements in the Winnebago Mental Health Hospital. We were $800,000 over budget looking ahead to 26 for just those emergency detention placements. Those will increase likely. It's that kind of thing, though, the forecasting of what the impact will be and the planning around what we can do to mitigate it, that we will work closely with our hospital partners, law enforcement, any other community partners that we have in our county to ensure that we do everything that we can to mitigate the damage as much as possible.
Well, thanks, Bob. Given that we have a limited amount of time, I think we'll move into our open Q&A now. Sorry that Adam and Brandon, you are unable to respond to that question. So I'll welcome Bill back and Tim, my colleague, also on to facilitate this portion of the program.
Hi, I'm Tim Connor, and I work at the UW Institute for Research on Poverty, managing a slate of Medicaid research programs. And I've been monitoring the questions that we're going to pose in this final portion of our session. Let me start with a question that came in. I think it's probably going to be more technical. And Bill, I think it's going to be directed to you more in this case. But the question is, when budget cuts are made to Medicaid, how is it determined which programs are affected?
That's a really complex question and a complex answer. Budgeting for Medicaid is both an art and a science, especially in Wisconsin, where we budget for 2 years. There's a lot of variables that go into the $15 billion a year that's budgeted, right? So what we try to do is try to find efficiencies, try to find effectiveness. What we want to stay away from are changing who's eligible for benefits, reducing benefits that are covered under Medicaid, or significantly cutting rates we pay to providers. At the end of the day, those are the three big drivers, right? When you do the multiplication to get to the final number of how much are we going to spend, it's primarily those things. However, our goal first and foremost is to try to stay away from those things. So how do we tweak around the edges to maintain our costs within the budget? Again, I think if you've been looking at national news and you've been seeing a few other states, Wisconsin is in a better position than several states in terms of our overall Medicaid budget, because the governor was able to get the budget done before the federal bill, which put us on much firmer footing. And because we're a non-expansion state, yes, would expansion help individuals that the administration has been pushing for over 8 years now? Yes, but the new bill it kind of muted some of the impacts on Wisconsin because we didn't expand, for better or worse, right? I think better for the state, worse for individuals. Again, Wisconsin's special, and we put us in that middle category. So I don't know that totally answered the question. I guess the answer is it's pretty complex, but we try to stay away from direct impact to individuals served in the program.
Okay. All right, thank you. Let's move to the next question about cost savings. There is a provider that participated in a 2-year Medicaid pilot program evaluating the impact of care coordination services on high ED utilizers that were Medicaid members, integrated care coordination program. If the number of uninsured adults is going to increase, it seems to me that services that lead to cost reductions and cost savings should be re-incentivized, such as the former example. Is there any talk to provide coverage for such critical cost-saving services for healthcare providers?
So I'll start first on the Medicaid side and then zoom out to the broader Department of Health Services, right? In Medicaid, we can only pay for Medicaid enrolled individuals. It's one of the primary limitations of our funding, right? So I can't pay for a program for people using Medicaid dollars that are not enrolled in the Medicaid program. However, I talked about the Rural Health Transformation Funding, which is supposed to be sort of this transformative really investment in our healthcare system. Could be something that the state could look at as we move forward with our application, sort of on a broader, how do we find more effectiveness and efficiency in our healthcare system across the state.
Anybody else on the panel want to comment on that question specifically or more generally about incentivizing cost savings?
Well, I can just say that we've spent the last several years focusing on those early intervention services like peer support, co-responders, and any sort of early intervention, substance use counselor in our CPS division to work with parental substance use. But the idea was to prevent those deep end costs. There are other avenues to do that through opioid settlement dollars or through other grants, federal grants, other grants that might help to fund those positions, at least short term. But I think that's the goal. Obviously, it was the goal of the ACA to move upstream of these deep end costs and keep people well, not just treat them after they become sick.
Okay. Let's move to a more general question now. I think some of you have commented on this to some degree, but one individual is asking about other forms of support, locally, state, wherever, that might be able to fill some of these gaps in coverage that we've been talking about today. So if you want to comment on the ways to increase support or increase services in your communities for those that are going to be most affected by these budget cuts?
Well, I can speak at a local level, and it's not going to be an optimistic tone in regard to that. There really isn't funding available to fill those large-scale gaps in. And we look at a number of folks becoming uninsured and seeing those gaps. At least from a county perspective, the resources are not there to fill those gaps. We continue to do the best that we can and navigate situations and try to assist people. But Medicaid being in such a large pool of funding and folks being facing being uninsured, it's not realistic for counties to be able to step up and fill those large gaps. Certainly, we do the best with what the folks that we have to try to assist folks and navigate those resources. But seeing a significant decline in Medicaid eligibility certainly it's not something that a county government would be able to fill in, at least Wood County government, a county of a medium-sized in Wisconsin. I don't see it as possible.
Anyone else with comments on that issue? Okay. I think we have time for maybe one more question then. We've talked about effect on members, the healthcare system in general. What about impacts potentially on and the general condition of the healthcare workforce? So this question seems to be about the healthcare workforce and the status of that workforce in general and how it, as a companion force, is going to impact these changes that are coming. Anyone on the panel?
Well, I would say for our county anyway, the workforce is there right now for many of our open positions. I think the challenge will be is that we won't have the finances to hire them. So I think we're okay in terms of workforce. I think the healthcare system, will there be an influx of people looking for work? because of the changes to Medicaid. But I don't think the workforce, a lack of workforce is the issue so much as being able to afford to pay for the people that we need.
Yeah, and I think a lot of these last questions, this chain of questions, kind of comes back to money and financial considerations that we all wish we had better answers for. But if I could just kind of speak to a little bit of what Bob was saying before about kind of frustration and anger over these things, I think underneath that it's important to remember that there's a lot of confusion, and a well-informed, well-educated healthcare workforce is going to be there to help dispel that confusion. And to what Bill was saying before, getting that information to people is going to prevent a lot of loss of coverage in terms of Medicaid, in terms of getting people into other programs, in terms of reducing uncompensated care. Because when people have access to these programs, they use preventive care, they access services, they are healthier and their families are healthier. So really, at the end of the day, Bob gave us that shot of optimism to say that we have that storm coming, but we could brace for it. And I'm just really trying to maintain a little bit of optimism as we are here in this panel, kind of sharing knowledge with each other and making sure we are going into the next couple of years as informed as possible, and we can help our members and the people we work with stay informed as well.
Okay, thank you, Adam. Okay, with that, we're at 1 o'clock. I think we're going to close out, and I want to thank you, Adam, for joining us from Covering Wisconsin, Bob and Brandon from St. Croix and Wood counties, and especially Bill, of course, for going over all these federal Medicaid policy changes and associated state budget changes that are going to kind of lay out some impact on our landscape in healthcare in Wisconsin going forward. A couple quick reminders: the Wisconsin Knowledge Boost sessions like this will be scheduled on a quarterly basis, so look for future announcements for the next one. And there's a link to this recording of this session that will be distributed to all registrants within approximately the next few days. So you can look for that as well. So with that, thank you all for participating, and we'll see you next time.